So hi everyone, I'm Benson Chen. I'm a neurologist and a neuro-ophthalmologist. I did my training in neurology in New Zealand and then took another year and a half doing special training in neuro-ophthalmology, which is a very subspecialized specialty within neurology and ophthalmology. So kind of you can think of me like as an eye-brain kind of person, but it gives me a unique background and experience in understanding visual problems that can occur in MS. So I think one of the quotes that I think sort of best summarizes or encapsulates how our brain and our vision works is that the eyes look but the brain sees. So what essentially that means is, we always think that it's the eyes that are doing the seeing for us, but really the way that the brain works and the eyes work and the way that things are structured is that the eyes are essentially like a camera that sends the information to the brain, which then processes that information to sort of give us a perception of the world around us. So really, the eyes are only there to act as a camera. It's the brain that does all the seeing. And I think one of the sort of really interesting things about the brain is more than 50% of the brain has some sort of involvement with vision, whether or not that be carrying the information that's coming from the eyes to the brain, or pathways that are involved in positioning the eyes, or pathways that are involved in processing that information there. A lot of the brain has to do with vision. And so multiple sclerosis as a disorder that affects a lot of different parts of the central nervous system can essentially cause lesions in any sort of pathway that involves vision, and as a result you can get visual problems from MS by a variety of means. So I think a lot of people with multiple sclerosis and in the community will recognize and understand that optic neuritis is a common occurrence in multiple sclerosis. 20 to 40% of people who develop optic neuritis, that will be their first presentation of MS. But we also forget that there are other things that can affect the eyes and the control of the eyes that lead to problems with vision as well. And so, for example, in order to see well, in order to see one image, we've got to have the alignment of the eyes perfectly straight. And so if one eye is slightly turned inwards or outwards, or if the coordination or control of the eyes isn't quite right, that can potentially lead to issues with blurring, or if the eyes and the way that they're moving are completely separate from each other, that can potentially lead to double images or two very clear separate images as well. So I think one of the other things that a lot of people sort of are very interested in with regards to optic neuritis is, well, if multiple sclerosis is a disorder that affects the central nervous system, then why are my eyes involved? Surely the eyes aren't part of the brain. But I think one of the really, really fascinating things about the anatomy of the eye is, we understand that in order for the eyes to work, essentially light has to go from the front of the eyes to the back of the eyes to the retina to pick up all that information around us. And then that light energy gets converted into electrical energy, and that electrical energy actually is then carried through a neuron, so a big nerve that actually goes from the back of the eyes through the optic nerves, through the pathways in the back of the, in the back parts of the brain to reach the occipital cortex. And so that tissue that carries that information, that optic nerve, actually it's just brain tissue itself. It's exactly the same as brain tissue. And so you can imagine if something can affect the rest of the brain, then the optic nerve is also likely to be affected as well in multiple sclerosis, which is why, optic neuritis and visual problems in MS is such a common occurrence, and a significant issue for people with MS living in the community, because as much as we like to think that after optic neuritis the vision improves, the reality is the recovery isn't perfect. Visual problems will fluctuate, throughout the day, throughout the lifetime. And we also have to remember that, things that can happen to anyone else without multiple sclerosis can also affect, people with multiple sclerosis as well. So I think that's sort of the added challenges of working, within this field of trying to make everyone's quality of life better, particularly if you've already got visual problems as a result of MS. So optic neuritis, I think, would probably be the most common sort of manifestation in terms of vision and visual problems in MS. The other really common one is disorders of eye movement. And so by that, we know that, the brain stem, which is sort of the back part of the brain heading down towards the spinal cord, contains a lot of the control centers of the brain that control your eye movements and where your eyes are positioned and where they should be. And so when you're sort of looking around in different directions, so for example, if I'm looking left this way or looking right this way, different parts of my brainstem are being activated to make sure that the little eye muscles that are surrounding my eye, which essentially act like little pulleys, all of them work in coordination. And so, with my left eye, things are getting pulled that way to look that way. With the right eye, the same pathways are being activated to pull the eye the same direction as well. But with multiple sclerosis, if you've got issues with the brainstem and you've got problems coordinating those eye movements, any sort of slight deviation of one eye or both eyes can potentially cause visual problems as well. And so, that's another, major cause of eye problems or problems with vision in patients with MS. The other sort of big group that I like to think about is the patients, once you've had your attack of optic neuritis, well, does it mean that, the vision comes back completely? Am I going to be completely okay? The reality is, although the vision does improve and, people sort of report that they're seeing a lot better, they don't have that big blurry spot in the middle of the vision, the optic nerve itself, like the rest of the brain, with the scar that's being formed from the multiple sclerosis, obviously, multiple sclerosis, multiple scars, the scars that are there essentially can cause ongoing dysfunction as well. So for a lot of people living with MS, some of the symptoms that you might have ongoing or coming back and forward after an attack of optic neuritis would be problems with saturation of color, so things don't look as bright or as sharp. And like the rest of the brain and sort of other symptoms of multiple sclerosis, if you're feeling tired, if you're feeling stressed, if you're feeling anxious, some of those older symptoms will start to come back. So the vision might get a little blurrier, or you might find that actually the double vision's a little bit worse towards the end of the day. And it's not necessarily because you're having another attack of optic neuritis. It's the exact same reasons why, someone living with MS who's perhaps had a previous attack of transverse myelitis might just find that on the good days things seem to be working just fine, but on the not so good days you're finding that your mobility is a little bit shot or that your balance isn't as good. It's exactly the same with the optic nerve and vision, as well as the control of the eye movements as well. So people living with MS will be very familiar with those good days and those bad days, and it's the exact same thing with the visual symptoms of MS as well. We always think, well, if it's sort of those classic symptoms of MS that we're all familiar with, or even the MS fatigue, which is obviously a massive problem for the MS community, you almost kind of think, well, if it's not that, then it must be a new symptom, or I must be having another attack of optic neuritis. But if you kind of think, well, the optic nerve in itself is actually brain tissue, exactly the same, those sorts of issues will still occur when you're tired, when you're stressed, when you're anxious. And the main thing is, obviously not to get fixated on it, don't stress out about it, because often I find, with the patients that I work with, as soon as you start sort of fixating about it, getting worried about it, you start thinking more about it, those symptoms, you sort of get into a bad spiral. And I think we're all guilty of that, irrespective of whether or not you're someone who lives with MS or you don't have MS. When we start to feel tired, run down, and we start to focus on our symptoms, a lot of those symptoms become a lot more noticeable, and then it becomes a self-fulfilling prophecy. And so, the main thing is to reassure yourself that actually it's not another attack, it's probably just reoccurrence of my old symptoms. And like with any other symptom that you have in MS, take a break, have a break, let yourself recover, have a bit of a rest, reduce that stress and anxiety. And, if it means having to go to bed, have a nap, reset, write off today, tomorrow you should be absolutely just fine. So optic neuritis is a topic which we can talk about, for hours on end. But I think the sort of key points for the, MS community is that, optic neuritis is obviously a very common presenting symptom of MS. And it's a diagnosis that's made clinically. So what we mean, in the medical world in terms of a clinical diagnosis means that it's a diagnosis that's made based on the information that the patients tell us, what we as the clinicians see on exam, and what we can find on things like, on MRI scan, or even photography in the back of the eyes with, fancy machine like this that I've got sitting next to me. So there's no test that we can do that tells us as the doctor whether or not a patient has optic neuritis. If there was, it would save a lot of time and make life so much easier. But at the end of the day, it still relies on clinical acumen, so us putting together the story and figuring out what's going on. So, with a lot of presentations of optic neuritis, we sort of divide things roughly into what we call typical optic neuritis and atypical optic neuritis. And it's not a terminology that I like to use because, if you talk about typical optic neuritis, often, clinicians, often doctors will say, well, you can't have optic neuritis because, what you're describing isn't typical. But, I think that's a complete disservice to patients because, for patients who are experiencing the disorder, I think, when I think about the times that I've been a patient, obviously want to be really helpful and give, the doctor as much information as they can have to sort of put the story together. But I think, in terms of what is the experience like for someone having typical optic neuritis or, optic neuritis that's associated with MS, often the optic neuritis will start off with discomfort around or actually feeling like in the eye. And the reason for that is when the optic nerve becomes inflamed, like inflammation anywhere else, in the brain or the central nervous system or the spinal cord, it can be very uncomfortable. And we've got lots of little pain fibers that are around the eye. Whereas I'm sure, most of the MS community will know that there are no pain receptors in the brain itself. So when you have an attack of demyelination somewhere in the central nervous system, you won't necessarily feel that pain. But I think we're quite fortunate in the land of, neuro-ophthalmology that with optic neuritis, more than 90% of patients will describe pain, and often the pain is quite severe. So it's not sort of, like a little bit of a headache or a little bit of a discomfort, like you've got something in your eye that you've got to rub. And often the pain is exacerbated or it's made worse by moving the eye around. And because optic neuritis in MS typically occurs just in one eye at a time, sometimes it can occur in both eyes at the same time, but more often than not, it occurs in a single eye at a time. The sort of symptoms that a patient would describe would be pain, worse with eye movements, which progressively gets worse, and at the same time the vision will start to fade out. And it might actually begin with sort of losing color saturation. So if you sort of compare one eye at a time, and that's something I really encourage people to do, if they notice visual symptoms, check one eye at a time. If it's one eye that's affected, so let's say, for example, if I've got optic neuritis in this eye here, my right eye, if I cover my right eye and I'm seeing completely well with my left eye, and then I cover my left eye and I'm only noticing problems in my right eye, that's much more suggestive of an issue with the optic nerve and the eye. Whereas if you're noticing something, it feels like it's just on one side, you sort of cover one eye, cover the other eye, and actually both eyes are affected, it's more likely to be something coming from the brain. Okay, so that's why if you sort of come to the eye clinic, one of the things that we like to ask was, did you sort of check? Did you check and did you cover your eyes? Because if you're noticing it's just one eye, you've got severe pain, the color, you're losing color saturation, you're losing central vision, so vision in the central part of your vision, it's getting really blurry, and over the course of a couple of days, it's getting blurrier and blurrier and blurrier, and the pain is not settling down. That sounds very typical of optic neuritis. There are some things that make me as a doctor very concerned. So if you think that you're having optic neuritis and the vision suddenly goes black within a couple of seconds or minutes or even hours, that would be a medical emergency. Don't sit around waiting at home if you lose vision suddenly. That suggests something perhaps happening in the retina or even a stroke of the eye. The other thing to consider is that if you're losing vision and the vision gradually gets worse and worse and worse, and over say, 1 day or 2 days, the vision goes completely black and you can't see anything out of an eye, that's also not typical of optic neuritis as well. And that's also a medical emergency. And you should definitely either go see your optician or go and see your GP. Or if you can't get an appointment with an optician or a GP urgently, then coming into hospital to have that looked at is absolutely fine. I think one of the things that's really important for the patient community to know about, and I think one of the really other common questions that we get is, have I had optic neuritis? You know, if I was the patient, have I had optic neuritis? Is there any way for my doctor or my optician to tell me whether or not I've had optic neuritis? And we all have little anecdotes about, 10 years ago, our vision went blurry for a couple of days. We had a bit of a watery eye, it was a bit sore. And then, you get an appointment or you don't get an appointment and no one can tell you for certain whether or not you've had optic neuritis. And it's a big deal because, if you've had optic neuritis, potentially there's, ongoing disease activity, and it really should be a big sign that, perhaps, the treatment needs to be changed. If your DMD needs to be changed, that needs to be dealt with. So one of the really cool things that's been discovered over the last 5 years due to research actually, and it's sort of international research that lots of people with MS have participated in, perhaps even some of the, people who see the MS team down at Queen Square, is that in the eye clinic we have a special camera called an optical coherence tomography, or OCT. And essentially what it does is it can measure the thickness of the nerves at the back of the eyes. And so after an attack of optic neuritis, we know that the nerve becomes thin over time. And so if anyone's had a previous attack of optic neuritis and we want to check whether or not what they had was optic neuritis, you can do an OCT scan, and that can actually tell us fairly definitively whether or not anyone has had actual damage to the optic nerve. So it's very useful, and it's a really helpful test to do, and it's something that we've incorporated quite regularly as part of our clinical practice. And I think related to that, one of the other things that I think a lot of people with MS who've had optic neuritis will be familiar with is, after you've had an attack of optic neuritis, the optic nerve, once it becomes damaged and it starts to thin down, it starts to become pale over time. And so when a specialist or when the optometrist is looking at the back of the eyes, they might notice that the optic disc, sort of, the thing that looks like a fried egg with spider legs or whatever, that actually, instead of being sort of a nice pinky orange color, it actually becomes pale. And, if you've got someone who isn't aware that they've had optic neuritis in the past, even just looking at the back of the eyes at the optic disc can actually tell us whether or not there's been any damage to the optic nerve. And then it's a matter of figuring out whether or not it was related to MS or something else. So if you do have questions about whether or not you've had optic neuritis in the past, or if you just want to get it checked out, certainly talking to your optometrist about it, or if you're coming for eye appointments and eye checks, talk to your ophthalmologist, and they'll be able to at least give you some clues about whether or not something you've had in the past was related to optic neuritis or not. Yeah, so one of the things that I think opticians are really good at is sort of, having access to all the imaging that we've got access to in the eye clinic. So a lot of the tests that we do in the ophthalmology clinic, any of your high street optometrists or your optician should be able to have access to those things as well. So we still really depend on our, colleagues, in the community to help us try and identify some of those issues. But the problem with optic neuritis in particular is that there may not necessarily be any signs that the optician or the optometrist can pick up. So one of the things that we look at in trying to help us determine whether or not a patient has optic neuritis is the appearance of the optic nerve or the optic disc at the back of the eye. So if you've ever looked at a photo of your retina or the back of the eye, there's a little bit that looks like a fried egg or a spider with spider legs that come out. So that's the optic disc. So people say, well, what's the optic disc? What's the optic nerve? I think the sort of best analogy I can give you is if you think about horror movies or zombie movies where the zombie's sort of walking around and then the eyeball pops out. There's that stringy thing that connects the eyeball to the brain. That's the optic nerve. And so in optic neuritis, it's that little stringy thing that actually gets inflamed or damaged as a result of MS. When an optometrist looks at the back of the eye, for about 30 to 40% of patients, the optic disc, which is that fried egg thing, it can actually swell up. And that's a good clue that there might be optic neuritis that's there. And so when the optometrist sees that, that's a big clue and a big warning that actually we're probably dealing with some sort of inflammation or swelling or damage to the optic nerve, and it needs to be dealt with and it needs to be seen, fairly urgently, particularly, if someone has developed vision loss very quickly over the space of, 1 or 2 days. The problem, though, is that, if only 30 to 40% of people have swelling of the optic disc, you've got 60 to 70% of people who don't. And, in that case, you're really dependent on the optometrist taking a good history, getting a good story of, the symptoms that you as an individual, who think you might have optic neuritis, what you're experiencing. Because, if you're saying I've got lots of eye pain, it's worse with eye movements. Before I lost vision, I noticed that things weren't as bright, in the eye when I sort of covered them up. That gives the optometrist a very big clue and a very big warning that potentially we're dealing with optic neuritis and the patient should be seen. And so an optometrist may not necessarily see any signs there, but they'll be very dependent on, asking good history. If it's not optic neuritis, let's say, for example, it's the eye movement thing, it's also very dependent on how the optometrist examines a patient's eye movements. And some, optometrists are very comfortable with that, some aren't. And I think, one of the challenges that we deal with in the neurology community, which, the MS community will be very familiar with, is that in a lot of the medical community and in the general lay community, there's, a massive neurophobia. So everyone's terrified of neurological things. People don't understand neurological things, and it can be a big barrier because if you don't understand what's going on, it's very difficult to advocate for your patients. And so, we'd like to think that all our GPs are fantastic and they can make, spot diagnosis of optic neuritis on the spot. But the reality is that, it's a very difficult diagnosis to make, even for neurologists who aren't familiar or comfortable or seeing patients with optic neuritis or MS, all the time. That actually, as a patient, I think the most important thing you can do for yourself is being clued up and aware of what those symptoms are, what they feel like, what are kind of some of the buzzwords that you should be saying to your doctor, to your optometrist, to make sure that you're getting the care that you deserve. Because I think, for a lot of these things, because it's a clinical diagnosis, it relies on someone telling a good story about what's going on. I think that's sort of, one of the biggest challenges. If you're not someone who already has an established diagnosis of MS, it can be very confusing because, I've heard of stories where patients almost get accused of making things up, or the optician or the ophthalmologist or the doctor or whoever the healthcare professional is, almost sometimes minimizes the symptoms, because for a lot of people, particularly in the optometry clinics or in the ophthalmology clinics or in the eye clinic, a lot of them are very dependent on seeing the problem that's in the eye. And for a lot of, eye conditions, you can see the problem that's there. If someone's developing cataracts, you can see the cataract. If someone's got a problem with their retina, macular degeneration or retinal detachment, the eye specialist can see it there. But for neuro-ophthalmic disorders, so neurological disorders that affect vision and affect the visual pathways, your eye healthcare provider, your eye doctor, your ophthalmologist, your optometrist, if they can't see it there, it's very challenging for them to make the diagnosis, particularly when taking a good medical history and sort of trying to get a feel of the story of what's going on is very challenging. And so for some people, if you don't have an established diagnosis of MS, it can lead to delays in getting getting a diagnosis of MS. And, particularly in this day and age where we've got access to so many fantastic disease modifying treatments, having an early diagnosis is really important. And, there are also issues with, does the optic nerve count as part of the diagnostic criteria for MS and things like that. And it's a sort of an issue that we as neurologists, MS specialists and neuro-ophthalmologists have to grapple with. But I think, the key thing that I really encourage people to do is if you feel that your vision isn't quite right, try and understand what might be going on. If you're being told that actually it's not an issue and things aren't settling down, it's okay to ask for a second opinion. It's really okay to, ask for help from someone else. And certainly, in the neuro-ophthalmology clinic, so it's a special subspecialty within neurology and ophthalmology, we're probably the best specialty to deal with these kinds of things. And I think neuro-ophthalmology, we're positioned in a really nice place, I guess, because the ophthalmologists are great at looking at the eyes and understanding what's going on in the eyes, but they're terrible with things like the optic nerve and understanding neurological conditions, whereas the neurologists are great with all the neurological things, the MS, but when it comes to regular things that can happen to the eye, it can be very challenging, and as for the general community, you think, well, surely my doctor should be good at everything. The reality is, we're all good at things in our own lane. We tend not to drift out to other people's lanes. So, having a specialty in the middle like this is really helpful and unique. What treatments are there? It really depends on what the underlying problem is. So if we go back and talk about optic neuritis, we know from natural history studies. So natural history studies are essentially where, we track a group of patients with optic neuritis, we give them treatment or we don't give them treatment, and we see what happens to their vision. A lot of these studies were done in the 80s and the 90s, and there was also a big clinical trial for optic neuritis. What we understand about optic neuritis is if you don't treat optic neuritis, for most patients, for the majority of patients, and it's a very high proportion of patients, the vision loss will actually stabilize over 10 days. And actually after around 10 days, 2 weeks, the vision will actually start to get better on its own. That pain that we were talking about with, moving the eyes around, that'll actually settle down on its own as well. So after around, 10 to 14 days, after around 2 weeks, 3 weeks, things will actually settle down on their own, and gradually the vision will actually get better on its own without any treatment. And so for most patients with optic neuritis related to MS, the vision and the visual recovery is fairly good. And by a month or 6 to 8 weeks after the initial onset of the attack, vision will sort of recover to a very, very good level. And then after that, we're dealing with, the vision occasionally getting blurry on its own for whatever reason, the color vision not being as sharp or clear as before, and sort of ongoing issues like that. For some patients with optic neuritis, we can treat with steroids. Steroid medication in themselves, as everyone in the MS community is aware of, some of the challenges with steroid medication. The best evidence for steroid medication in optic neuritis is that actually if you're going to treat someone with steroids, it has to be high dose steroids. So it's almost the exact same dose that you would use for treating an MS relapse involving any other part of your brain manifesting with any other symptom. And all of us know that, high dose steroids have all sorts of issues, problems with your gut, problem with insomnia, feeling a bit wacky and doolally, all those sorts of issues. And so is there any benefit giving high dose steroids in optic neuritis? The answer is no, not really. It actually speeds up your recovery. So that whole, 4 weeks, 6 weeks, 8 weeks thing of, the vision getting better on its own, giving you steroids or giving someone high dose steroids will increase that recovery, so speed it up, but it doesn't actually make that recovery any better. So for most of the patients that I see with optic neuritis related to MS, the first question is, well, how much of a bother is the symptoms at the moment? If it's just one eye affected, you've still got the other eye. If the other eye is actually fine, it's just a bit of a bother, and you don't want to put up with the steroid side effects, then actually most of the patients I see are quite happy not having any treatment, and just seeing how it goes. And I'll bring you back into clinic, in a couple of weeks, usually not more than sort of 10 days to 2 weeks, to actually see what kind of recovery has improved, just to make sure that that vision isn't getting any worse. Because like I said before, if the vision does get worse, that sets off alarm bells that perhaps it's not optic neuritis and we're dealing with something slightly different. So with regards to other visual symptoms of MS and how you can treat it, if it's the issue with double vision, because double vision related to MS is a problem with the alignment of the eyes. If you're having an acute relapse, so a problem right now with the vision and the eyes aren't moving in the right way, one of the easiest things that you can do is just to patch the eye. You can get an old-fashioned pirate eye patch, cover up one eye. If you're needing to have clear vision for things like reading or using the computer, putting an eye patch on, or even for someone like myself who wears glasses, you can actually tape over one eye with translucent sellotape or sticky tape, and just blurring out one eye is enough to actually give you good clear vision in one eye so that you're not too bothered by the double vision. And we know, like any other relapse, you know, if the relapse is involving the brainstem and the part of the brain that controls those eye movements, as things get better on their own, the separation between the images that you're seeing with that double vision will actually start to get better on its own. And what you're left with might be slight off vision, in which case, you know, you might get a little bit of overlap or blurring, which can be quite frustrating, particularly if that's a residual symptom that you're left with, or things might actually just fuse together. And one of the really amazing things about the brain is that, you know, all of us have experienced double vision at some point. You know, if you're sort of reading up close and you can't get your eyes in together, or if you're looking away in the distance, your eyes have to spread, you know, have to move apart. Sometimes with a bit of willpower, focusing, energy effort, you can actually get the eyes to, you know, move in or move out. But it can be very, very tiring to do that, particularly, you know, if you've got MS. And so often in that case, if you're finding that, yeah, my double vision's come back, it's a bit of a hassle, I'm trying to read something, or I'm trying to drive, or I'm trying to use the computer, covering up one eye, you know, is absolutely fine, because that enables you to not have those two images that are there. You're just having that one image that's there. But if you're having those problems, obviously, with driving, it's very important to talk to your optometrist or your ophthalmologist, because there are implications for, you know, after optic neuritis, your degree of visual recovery or what your eyes are able to do will dictate potentially, you know, whether or not you can sort of get back to driving. Obviously, we sort of interpret those things in the context of other issues that you might have with your MS that might interfere with driving as well. So usually, you know, for most people, after an acute relapse of optic neuritis or problems with coordinating the eye movements, things will get better. Steroids improve the recovery or speed up the recovery, but with optic neuritis, I don't think there's any real benefit. With the eye movement stuff, potentially it can improve the recovery. Particularly, you know, you don't want to wait 2 weeks waiting for that double vision to settle down. And if it's really, you know, a bit of a bother, actually steroids might help with that. So that would be sort of a situation where I really encourage someone to talk to the MS nurse or their MS neurologist.